Yeah, thank you. I'll just keep my comments brief. So this is the first of a number of different of virtual speakers that we're going to be having, and just we're so excited to have Dr. Claradina Soto present on her work. So what I'm going to do is I'm going to transfer this over to Dr. Jennifer Unger, who will do the introduction for Claradina, and Dr. Unger is part of our IAS steering committee. So let me toss it over to Jennifer and let her take it away. And thanks,
Okay,
Kristen.
thank you, Adam. I'm pleased to introduce Claradina Soto, my long-term friend and colleague, who is an assistant professor here at USC. She's been working for many years in tobacco control in American Indian communities, where she started out as a service provider in the community and then came to USC and became a researcher. And she has a really unique ability to speak both languages, to communicate between people in the real world and people in academia. She's done prevalence studies of tobacco use among American Indian communities. She's done a cessation study. She's doing prevention studies. And recently, she has had the opportunity to become a major figure in the opioid epidemic in American Indian communities too. So she led a statewide needs assessment and also an evaluation of programs that are currently going on. And she'll talk to you about that today. So this is a rare opportunity to talk to someone who really understands the health issues that are affecting our communities and how we as researchers can help alleviate the public health problems.
Awesome, thank you, Jennifer. Thank you everyone for everybody who's been able to join today. I'm hoping to speak for maybe about 40-45 minutes, but it just depends. I get so passionate about some of this work that we're doing here. But yes, thank you, Jennifer. Today I am going to be speaking about the needs assessment that we were able to conduct here throughout the state of California to get the perspective of American Indian adults, youth, and healthcare providers that work in the Indian clinics throughout the state of California. We are doing some evaluation work throughout the state, which I will share some of those programs and what they're doing to address some of the needs that have been shown here in this needs assessment. But I don't have much of that shown because there's just so much to share with this story. So one is I'm just hoping to be able to increase your awareness about this community, this very unique, diverse community here in the state of California. Two, how the opioid epidemic is impacting this community. Three, what are some of the needs, successes, things that are working in this community, and then four, kind of some of these future directions as well. And I know that there were a number of questions, and I'll try to address as much as I can through this presentation. So thank you, everyone. Let's see here. Okay, so we are unable to do this without a team. We have many collaborators to conduct this needs assessment. It was a very huge project to really get the perspective throughout the state of California. So our collaborators do include folks here at USC, co-PIs, Jennifer Unger, Kim Miller, Dr. Amy West, who's at CHLA. We have Darren Urata from UCLA. We have our community folks from the SACUI, the California Consortium for Urban Indian Health. We have folks from CRIB, as we say, the California Rural Indian Health Board, so that's more the tribal communities. SCIP, which is the Sonoma County Indian Health Program. UAII is United American Indian Involvement. And then we have the NCIDC, the Northern California Indian Development Council. And this is such an amazing team that really has the collaboration of academic and community. So with every presentation, I always begin with just trying to give a little bit more of an understanding of the population of the Native community here in the state of California, where California does have the largest American Indian, Alaska Native population in the US. There are over 100 federally recognized tribes throughout the state of California, and many statewide tribes that are also trying to get that recognition as well. But we also have a number of American Indians, Alaska Natives in California who are urban. So they have relocated from other states, here trying to seek employment, better opportunities, raises a family. here I myself am an urban Indian from Northern California. So we're born and raised in the East Bay. Both my parents came through the relocation program here from their respective communities. So sorry I didn't introduce my tribal affiliation. So my mother is from the Navajo Nation. My father is Pueblo from New Mexico. So their reservations are maybe about 2-3 hours apart from one another. But they met out in Northern California through the relocation program. And for folks that may not know what that is, that was the US government's one of their systematic ways to assimilate the American Indians into Western society, to acculturate them, to remove them from their cultural ways, their cultural land. So, but we have family still back home on the reservation, and sadly, COVID-19 is absolutely impacting many of our communities, particularly our community in the Navajo Nation, but then also the Pueblos as well. Just quickly, you know, there are 19 Pueblos in New Mexico, and once it, you know, they're small communities, so they're really working hard and keeping strict restrictions to keep the community and staying at home. So that's just really important in itself. But again, these are, this is just some of the urban Indian populations in California, but then all the number of tribal communities that exist here in the state of California. So there's just so many communities, very hard to reach for some. Urban Indians, maybe not. It's difficult to reach urban Indian populations. Oftentimes we utilize the agencies that primarily service this community as well. This is just to show Indian health programs that are here in the state of California, servicing the American Indian, Alaska Native communities. There are in California 35 tribal health programs, primarily serving the tribal communities. There are 10 urban Indian health programs that service the urban Indian population. And I don't want this to be or deceiving, because when you see this, you think, oh, there's so many wonderful, you know, clinics that are throughout the state of California, so all the needs must be met for this community. But that's not necessarily the fact, where many of these clinics are very small. The quality isn't that great. The funding isn't that great. That's a whole nother lecture in itself. But just so you know that, you know, we have these clinics. They do have some medication-assisted treatment programs, other services to address substance use disorders, but it's a lot of work still needs to be done. So part of this needs assessment was to understand what services were available, what barriers to get some of those services, or what services didn't even exist, and where that need really needed to be met to really help reduce substance use disorders and opioid use disorders in this community. So looking at opioid overdose deaths, we were able to gather data, which is really difficult for this particular community. It's really difficult to get up-to-date current data for this community, but we were able to source together through the California Department of Public Health with their vital statistics. And so we looked at their dashboard, and this does indicate that the death rates involving opioid pain medications were among the highest for American Indian, Alaska Natives when compared to other racial ethnic groups. So really showing how much this addressing the opioid overdose crisis is really important. And again, for us to be able to identify some of those gaps in prevention, treatment, and the recovery services here in the state of California. This here, I like to show this because, again, data, you know, we have to be very careful in how we read data. Of course, as many of you who are listening probably know this already. So when we're looking at overdose death rates with data from 2017, it looks like California, you know, shouldn't be much of a concern when you can see some of these other states more towards the east of our country. But again, when we're looking at different racial ethnic groups, our community definitely has a high impact, and much work needs to be done in this community, which is happening. And I'm happy to be able that I get to share some of that with you all today as well. But looking back at, again, some of the data that we were able to put together from the California Department of Public Health's vital statistics, we're also able to look at by county. This was really the driving force for us to know where do we need to go to get the perspective of our Native community for this needs assessment. So this at least gave us an idea of some of these counties that had really high overdose rates. And so going from the top, we were able to collect data from Del Norte, Humboldt County, Lake County, Sacramento, Yolo, Fresno, I know we did, Santa Barbara, all the way down to San Diego and Riverside. So these were just at least some of the counties that we were able, so we reached 12 counties in total, again, representing a number of tribal communities and the urban Indian population in the state of California. So again, trying to get northern, central, and southern as well. So we were funded to do this needs assessment by the Department of Healthcare Services, DHCS, which is funded by the STR, the State Targeted Response from SAMHSA. We're really excited that this funding has been made available not only for us at USC to do the needs assessment, but for us to conduct the evaluation of all the funded tribal MAT projects. There's currently 5, and I have a slide just to show you who those folks are in the state of California doing really good work to address this. So our needs assessment has really been essential in helping to drive those funded Native American agencies to help address some of this as well. And so we're really just thankful to DHCS for really seeing this population as something that getting the funding to be able to reduce the opioid use disorders and substance use disorders. And so again, we did the statewide data collection through our advisory board, folks that you saw at the beginning of this presentation. Again, through 9 months in 2018, we did a lot of traveling to the different communities throughout northern, central, southern California. Sometimes you need 3 days to be able to just visit one community because it takes 1 day to drive up 6-7 hours just to get there. And then you need a good night's rest to take another 2-3 hour drive to get to the community and then to meet with them, spend some time with them, and then get back to home base and then drive back home again for another 6-7 hours. So there's a lot of work in this, and communities were really happy that we made those strides to get to and reach these communities. And I think in all of my years conducting research and working in communities and partnering and collaborating, I think this has to be one of the first where I've been asked by the community for us to visit them. Oftentimes, you know, it can be difficult as a researcher trying to work with Native populations, but because this is such an important topic and they really see the impact this has in the community, they were asking us to come and make visits. And so many of, so we did our key informing interviews with healthcare providers at some of the different Indian health clinics, urban Indian programs. We did focus groups, 21 and 15 youth focus groups. And so these were community folks that were in recovery, that had family members that were in recovery, where they lost individuals to overdoses. And so these were really sensitive times, and we had to be really mindful of that. So oftentimes we started our meetings and meeting with the community with prayer, just to keep a safe space for our individuals when sharing very sensitive issues and things that came out in our focus groups. So that, and we always ended it with a prayer as well for our community members, just so that they know that that was a safe space for them. So just this basically lists all the major categories that came out in this needs assessment. Really looking at substance use in the community and understanding what those risk factors are for the high use of these different substances that were identified. Really understanding the resiliency. This is a really leading factor to really help us create culturally relevant interventions and programs, because with that resiliency, that's what we need to tap into to be able to better culturally modify and knowing that we're reaching the community in culturally appropriate ways. We were also able to understand what services are available that address opioid use disorders and substance use disorders, and the acceptability of these. There was a lot of stigma that came about by individuals and by providers and by the tribes sometimes, because stigma was really, which is something that is continually trying to be addressed by an individual not wanting to, they feel like they're being judged by getting services. Providers may not have that cultural understanding and might be passing judgment without them even knowing it. Or the tribe not quite understanding where the myth has been giving, substituting a substance for another substance, you know, with the medication-assisted treatment, right? Because we're providing medication prescriptions to help with opioid use disorders with the MAP program. And then understanding some of those barriers and what are some of those service system needs. So again, this is such a short time, so I'm just gonna address some of the first three. We don't have a lot of time to go through all of it, but I know that Kristen can give you access to our needs assessment. We have a full report that outlines all of this, as well as just like a 4 or 5 page executive summary as well. And so this is just a snapshot of the front cover of our full report. And then there's the link there. But again, I think Kristen can make that available to all of you that have participated in today's talk. So here is just the first 2 categories. The first is the community substance use. And we really just wanted to understand substance use trends and the access, right? So what types of access that was the community saying? So this quote here, I think addresses some of that here, where in the blue on the right side, it's an adult focus group participant that said, "My mom did a good job of keeping me away from the neighborhood, away from the gangs, away from all that stuff on the streets. The only problem is that I had it in my house with my brothers, can't run from that. I had a brother that was hooked on heroin, oldest brother. I had another brother that was using marijuana and meth. And I did a good job of getting away from that, you know, for a long time. Can't get away from my family though, because they're right in front of me. I didn't have to go to the parks. I didn't have to go inside the hood or the crack house. I didn't need the streets. I had it in my house." So there's a lot of reports of family substances and easy accessibility, unfortunately. But this just describes at least one individual's case and us trying to understand the accessibility to this. The other is, I think the top 3 substances that came out, because we did have individuals list the top 3 and we tallied them. Alcohol, I believe, was number 1. Marijuana use was 2nd. And then 3rd was together with heroin and opioid use within the community. The other is polysubstance use that we heard a lot from the community as well, and having to understand how to best address that. So it may not just be opioid use in general, but how do we address the other substances that one may be using. And so there are programs in clinics that do address that, because I had the opportunity to sit in at a clinic where all the providers, counselors, directors come together weekly and literally go through every single client to ensure that their needs are being met. Are they in phase 1, phase 2, phase 3 of the MAT program, the medication assisted treatment, which I think is also called MOUD, medication for opioid use disorders. And so they sit and they address all the needs of, and making sure that they are still in this certain phase. Can they graduate to the next phase? If they're using different substances, how is one counselor able to address that versus the other, ensuring that they're getting all the resources met. So that was a really great experience for me to understand how the clinic was really trying to address the patient's needs. Now, all clinics don't have that opportunity to be able to bring, they may not even have a provider, they may not have a waivered prescriber, or even a substance use counselor. So there's all these different things that come into play as to trying to understand how to best meet the needs of the community when certain resources aren't even in place. Let's see, youth initiation was another huge piece. We learned so much from our Native youth who were really open about substances that they may have tried as early as age 10, but how a lot of the youth programs helped them out a lot to, one, for them to keep part of their cultural identity and their and having a sense of identity and being able to help with the prevention piece. And I think the youth programs, at least with the youth that we had spoke with, said that really has helped them a lot to have a safe place to go to as well. I could talk on and on about all these different little pieces, but with the risk factors, there were a number of them outlined for like community stressors, historical trauma, and disconnection was a really huge piece that came out, I think, in all our focus groups and with among the healthcare providers. And really this was them just addressing how historical trauma has really impacted the loss of culture, you know, due to colonization, Western influences, and having an impact on their cultural connectedness and interpersonal relationships, both within the family and as a community as a whole. And so that's really something that I think part of the resilience that has helped us to address this. So one is having more interventions to help heal, to help understand things that have happened. So folks may have been through boarding schools where the government has taken, you know, their families and their children at a young age being raised by not their family, you know, by the missions. Again, relocation had a big impact on these families as well. So there's a lot of different cultural, not cultural, but a lot of different traumatic events that have happened, and which really outlined, and historical trauma was mentioned a lot, and intergenerational trauma with especially the young ones that may have not been through directly impacted by these traumatic events, but they do absolutely understand what has happened with their mothers, their grandmothers, and others, and that having an impact, and seeing just how that has been associated with high rates of depression, anxiety, and other things, which unfortunately may lead to these types of coping mechanisms of different substances and stuff. So we see this kind of cycle that's happening here, and I think it's still so important to understand one step at a time how to best address this for an individual. There's other risk factors that came in, you know, family stressors, economic stressors, poverty, homelessness. We were able to take a small piece of this, and we're coding some of the data for individuals who are experiencing homelessness that identify as American Indian from Northern, Central, and Southern California. And that came out of our needs assessment. So we're able to learn a little bit more about that subpopulation as well. Mental health, again, is a really big issue, and peer pressure, social norms. So there's a lot of those factors that came into play and are described a lot more in our needs assessment report. Resilience, again, as I mentioned, these are really the big caveats that are so important to help develop and continue the interventions and the programs to really look at community strengths of understanding that connection to the community, that spirituality for individuals, gaining that. And part of this is really balancing an individual's emotional, mental, spiritual, physical well-being for that. Cultural cohesion is another piece that is part of this resiliency as well. Cultural services are so important, and so more of these programs that can get funded, that can provide services, even during COVID-19 times. This is, I think, more needed than ever because of feelings of isolation, and especially when many of the community rely on these services that provide the cultural traditions or different ways where they are making, beading, their regalia, making drums. These programs offer these wonderful resources. And so I know that the United American Indian involvement down in downtown LA is really working hard to continue to service the urban Indian population. So they've actually have given bead work and all the resources and items at their doorstep so that they can connect virtually, so they can continue to learn to bead and continue to do these things. There's just other innovative ways that these agencies are really trying to connect with the individual so they don't feel isolated and they don't resort to any other things, and keeping their families safe. So there's things for the youth and for the adults and for the elders as well. I won't read these quotes. You can read them on your own, or again, they'll be available in the needs assessment report as well. And so just to give you an example, this is a recommendation that came out of this, which is really important, and it's to increase the availability of culturally centered recovery programs, really relying on this well-variety. And this well-variety is really kind of this, I'm not a substance use counselor, but it's been developed by the Native American community, really adapting the 12-step recovery model to help individuals and create the balance again between their spirituality, their physical, mental, emotional health. And so there's a number of ways to do this. And even one of the ways is to integrate cultural components to this well-variety piece of trying to create balance again. This is really something that came out, is that community members said if we don't have balance, somebody is then unbalanced, and then they are easily diverged into another direction. So bringing balance back to create better decisions for individuals, and creating better resources and creating better opportunities. This really can help help to improve their well-variety or their in recovery. And so part of those culturally integrated pieces that they want, part of these is different ceremonies or different traditional methods that really help them to be in their recovery programs. And so one was mentioned as the sweat lodge, which is really helping individuals to work towards their sobriety, or other healing ceremonies. And again, this could even be talking circles, praying, meeting with traditional spiritual healers. And so one good news, there's many things, but one of the good news that we had heard from the Department of Healthcare Service is based on this needs assessment they've put out to the state of California, because of the need for traditional spiritual healers, that they may be able to bill, different clinics or might be able to bill for individuals who are able to use these traditional healers, because before we're never paying our traditional healers, or we're not, that's not part of our insurance programs or these others. So that's another component and piece that they're hoping that the state and counties are able to where places can bill like Medicare, Medi-Cal for these types of services, cultural services that are helping the community. The other is, again, there's such a lack of residential detox sober living facilities that are primarily for American Indian Alaska Natives. There's a few that exist here in the state of California, and they're very well run, but there's just so much more that's needed to help meet the needs of these communities, particularly women and children. So there were a lot of mothers that may have been through some of these residential treatment programs that are inpatient, that they can't bring their children, and that's really difficult. And so I know that they said that there are existing programs, and if they could have their children with them during this time would really be helpful to them as well. Also coordinating of non-native provider program referrals. And so this is also providing additional resources to our community members is really critical of getting non-native providers to be able to refer Native individuals to the existing programs, or again, what we're actually doing, another step from this needs assessment, is doing this kind of comprehensive evaluation of all the programs that exist in the state of California. What do clinics offer? Is it direct services? Is it referral? But so that way other counties and other agencies like non-native providers know then what's available for them to be able to refer others to. So that the needs are being met, especially if folks want a Native specific provider or agency to help them in their recovery process. The other is one other recommendation of many is developing a more integrated collaborative systems of care. And this is so important because the key informants, the providers, really talked about just having the system of care to help an individual instead of where that there's one individual or a few people that know this person that can help them for the different pieces in their recovery, for counseling, for their medication, for adherence, for other things, but also then addressing their pain management. So that's another piece. That's a whole nother, I think, time that we would need, as well as understanding not just individuals who have opioid use disorders, but also where it might just been the pain that they were dealing with and how they were prescribed medication, and it became to the point where now they were not able to manage that use of their prescription, and now they're relying on this a little too much. Or again, there's other methods to pain management so they don't get these high doses of these types of medication. But again, the system of care is really then to help adherence, to help prevent relapse, and to just help really integrate, again, cultural practices and traditional ways to help one in their recovery process. So that's just, you know, some of the results that we got, some of those recommendations that we have. And so there's an executive summary, as I had mentioned, which really just pinpoints the recommendations that came out of this, which is really going to be helpful for policy stakeholders and for tribal leaders to be a part of this as well. I think that a lot of the education needs to happen at multiple levels, and this can really help, I think, on kind of the broader community organizational level, again, especially when it comes to tribal communities, because there's these layers of things that happen where we can talk to providers who know the need and are ready to start an MAT at an Indian health program, but then they have to get approval by the health board. And if they don't approve that, then that may stop the development of an MAT program. But then they can then go to the tribal council, who can then also say, this is something that we need. So they need to now negotiate and talk about how the development of an MAT program is going to happen, but they need to have all approvals from either the health board and or the tribal council as well. So I think this type of needs assessment really shows the need and the ways that they can help partner and collaborate and really understand. And the other piece is stigma. That's another big piece that just really came out of this, is just understanding how we're not giving one drug for another drug. And so really addressing that myth on multiple levels is really important as well. And so again, so now we have these evaluations of that we're doing as well at USC of these 5 tribal MAT programs funded by the department DHCS. And so you have to your left on the screen, the California Rural Indian Health Board and SUCUI. So they both have very similar kind of activities that they're doing to reach our Native communities from the urban side and the tribal side as well. And so they have the community opioid campaign. So they're creating materials to educate. So I'll have an example here of one of the culturally created materials too that can be shown at clinics and other places. They're doing a lot of training and distribution of naloxone to help reduce opioid overdose. And so not only is it that the providers have it, but community members have it, family members have on hand naloxone in case they need to administer to a community member, family, friend. They have MAT champions, medication assisted treatment champions in the community at just the community level, the clinic level, to provide TA services and to really just help make those connections with resources that are needed to help develop different programs based on what resources they have and what they're able to implement at the time. But they also, and the other thing that's missing on here is kind of like mini grant money. So they have small funds that they can give out to the tribes and to urban Indian health programs as well. And the other great thing that's happening is the coalitions. There's a lot of coalitions being developed now among the American Indian Alaska Native communities. And this has really been great for providers to attend, for the community to attend, for those that are in recovery that have gone through something, and they can really speak on behalf of how MAT programs have helped, how the cultural and traditional parts have helped them, how can we best integrate the two so that that can really help meet the needs of the community. So there's a lot of that happening, and that's really building up currently right now. We have the Two Feathers, which they've done a lot of great work in reaching tribal youth and families through their services as well. Project ECHO, this is based out of UCLA, but they have what's called a tribal ECHO. So following that ECHO component, where they're really trying to help support healthcare providers with monthly webinars, particularly to those who have just started an MAT at an Indian health program or urban Indian health clinic. And then TeleWell, this is something really important. I think that'll be used more than ever now, is the telehealth. So there's the TeleWell program that has been delivering telemat services, but also helping to increase MAT development at the clinics on site so that they can get a program based on the resources that they have. Again, do they have a waiver prescriber, a provider, a counselor, and making sure they have these things in need, and how can that support be developed so that they have a program on site at their clinic. And then this is just recommendations following kind of the socio-ecological model of how these recommendations can be at the individual level. So number one. Number two, at the interpersonal level. Number three, the organizational level. Number four, the community level. And number five, at the policy level. Again, and these 7 here on the right are just the categories that we were able to learn more about all the different pieces that came out of our focus groups and our interviews. And so if I can just mention again, you know, I think stigma is another really big, huge piece with interpersonal of really creating positive role models, that family support, and really that provider communication so that an individual does feel safe and they don't feel judged and when going into a clinic to get services and or help. The organizational piece, I mentioned a little bit about it, of how important it is to get the clinics on board and healthcare and health councils on board with this, but also kind of understanding that patient-centered care and how they can better improve it, or if they don't have it, to develop that so that an individual is getting the most care possible at their site. The community, a lot of different things. Again, I think, again, it was really having these residential treatment programs, sober living facilities, because once an individual has gone to Northern California where they have a Native specific treatment housing program, and once you're done 6 months or after a year, where do you go after that? And oftentimes they want to stay in their surrounding area now because they've been there for a few times instead of going back home to the reservation or going back home to family where they still need that time in recovery. And so there's really a big need for these sober living facilities to help. And harm reduction is another big piece that's new funding is coming in to help with these communities as well, even to the point where I mentioned that stigma with medication, trying to get rid of one and given another. But community is looking for traditional activities that they can attend. Because oftentimes our dances and others, we want it to be substance free, right? But if somebody is working on their recovery, but in a MAT program, that can be difficult and for an individual. And then policy, there's just a lot to be addressed in policy. Foster care actually came up a lot in funding Native youth foster care in this as well. So you see a lot of this that came up, and I'm just giving you a quick summary of things that with these recommendations. And again, I encourage you to look at our executive summary to look at these additional recommendations. So here's just an example, which is beautiful materials developed by the SUCUI, California Consortium for Urban Indian Health. And it's just a brochure. They have posters, but these are these little brochures of how to dispel the myths. So again, addressing stigma and just understanding addressing these myths that are in the right side here. But these are some beautiful pieces that have been developed by the community for the community. So more of this definitely needs to be done so that they know that this information is for them and these are made available. And actually not only has this been used statewide, but it's been used nationwide as well with other tribal communities throughout the US. Oh, here's the poster here. So with our work as an evaluator for the tribal MAT programs that are being developed at the clinics, there's actually about 20 right now. So I have 16 here, but there are about 20 clinics that are implementing or starting an MAT program right now. So that is really some great news. People are getting their needs met, but there's definitely still a lot of work to be done. And so then some of those potential next steps, obviously, is to continue this to help address opioid use disorders and especially the co-occurring disorders that exist in the community. We have been expanding our needs assessment. So not only have we reached out to those that are experiencing homelessness, but we have also, again, looking at kind of this comprehensive evaluation of what services are really available throughout the state of California, whether they're Indian Health Service funded or they're just funded by their tribe or at the clinic level. So just really understanding what services are available, because again, our needs assessment wasn't able to go completely across, but we had our reach as far as we can to get a nice representative sample. and then increasing efforts for recovery services, and then prevention initiatives. So I think a lot of the prevention really does need to gear towards our youth for sure, because as our communities say that the youth are our future, which may be in many of your communities as well, right? That philosophy that we have to continue to protect them and prevent them from substance use and other things so that they can be good, successful individuals in our communities as well. So that's definitely those potential next steps. And then my next slide is just, there were actually a lot of questions on COVID-19, and I think this has really, it's kind of had us to have, with evaluation and some of our work, having to step back a little bit, because these clinics are doing so much, these agencies are doing so much to really meet the needs of their communities right now. As I mentioned, they're doing a lot of virtual things, but a medical provider now could be calling every single elder, making sure that they have food and that they have their basic needs met. And so with our research, we've kind of put things on a halt, or just to do what we can at a minimal basis, but we don't want to be a burdensome to them right now, and just be supportive in ways that we can. There's some of the agencies, SACUI or CRIB, but I'm showing you here of just ways to help with the COVID-19 with other communities. Again, I know that the Navajo Nation is getting hit really hard with this being one of the top three. And then here, my cousin, as you see her name, Boogie Bones, she's from Jemez Pueblo, and she's just got an amazing story of wanting to help the community. So literally for about 15 days, she's made 100 masks a day. So she is just looking for support in more fabric. She's run out of fabric. She came to the point where she was selling some of the masks just to help supply her materials. But I said, I'm gonna show you to the folks that are whoever's on this call if they want. She said, I don't have a fundraiser. She goes, if they want, they can email me. But she is giving to all the different Pueblos and to the Navajo Nation as well with masks. So literally she is making on her own. Her husband cuts every now and then, but the fabric, but every day she's making 100 masks for the community. And then other here is the Pueblo Action Alliance, and they're also, again, so they're kind of working in partnership, but then I also just gave the Navajo Nation Relief Fund information there. But with that, I will stop there and take any questions that we have at the time. Oh, good, yes, I did 12:43. You're on mute. Okay.
That was perfect. Thank you, Dr. Soto. Great presentation. We do have a couple questions here for you. And then just a reminder to anyone who wants to be unmuted, please just click raise hand and I'll unmute you and you can join. We have a question from Anonymous. In terms of the other substances that were stated in the needs assessment, was meth a predominant substance that was identified?
Yes, so I wish there's so much more we need to do, but in some communities it was, in other communities it was not. It just depends, and I don't want to misinform, so I don't want to say, you know, Southern California had more than others, but there definitely was more of a higher substance use of meth in some communities versus it was another substance that was a much higher use, and meth was really not even considered an issue in that community. So it definitely differed, which is, I think, really important that I didn't quite allude to the fact that, again, they're very unique and diverse and their needs are also different. And so one way that something has been attempted in one community may not be the same that you'd want to do in another community, just based on, you know, beliefs and the way and their structure and just the resources that they have. So it's, you know, we can't take one cookie cutter approach and apply it to all. Again, even just as the question, what's the substance most being used at the community?
Absolutely, thank you. We have a live question from Dr. Jane Steinberg.
Hi, Jane.
Hi, Claradina. Excellent presentation.
Oh, thank you.
Quick question.
Yes.
Do you see a difference in the types of substances that are used in urban versus rural areas, or do they overlap?
They overlap. I think it was, it overlapped, and I think the two were more alcohol and marijuana and a little bit of opioid.
Okay, I'm just
From my
curious.
recollection. Yeah.
Thanks.
Thank you, Dr. Steinberg. Another question here for you. In terms of resources that are in the areas, are there any resources that are pretty predominant, like mental health resources? I know that you talked about the resiliency within the community and other, benefits, but what kind of resources are being provided?
Right. I mean, there's a number, again, and for mental health, I think that is so important. I think especially because, like I was mentioning, historical trauma was a really big piece. And I feel like that's such an underlying factor for all the kind of health disparities that exist and the inequities that exist in this community. And so, and that really has a big play on mental health. And so we did have a lot of expression and perspective based on depression, anxiety, and other things that were happening in this community. So those services that are made available is even just having programs that can help help their identity. You know, like I know that some of the urban Indian programs just have these programs to help keep them occupied or continue to help in their cultural ways and help with being a part of these, ceremonies and other communities as well. And I think that in the belief of the community is that, that really helps with your mental health, in part of that cultural connectedness and feeling and building that strength and building that balance with yourself. So there's all these like connected pieces. And I feel like our elders and our traditional healers do much better way of explaining this than I am right now. But those particular cultural services are so, so important. So that really is like those mental health services. So I think a lot more what needs to be done is really trying to show the evidence base, but our community does know that these are those practice-based, community-based programs that do work as they, anecdotally see this happening in their community. But I think more of these coalitions that are happening, the beauty of that is that they're learning about what services that they have at one location and, oh, that's great, we could do that at our location. So now these resources are being shared among our community to help address in ways that if they have those resources.
Thank you. We have another question here. How, that kind of links to what you were just talking about. How did the study identify historical trauma? For example, in the focus groups, interviews, surveys, etc., are community members specifically identifying historical trauma, or are they describing historical and intergenerational traumatic events to you?
Both, all of it. It's such a known thing. So if they talk about the colonization, the removal of reservations, the historical traumatic events that have happened in their communities over time, to where for those saying living on the reservation, this is what these traumatic events has done due to the colonization of these communities, is put us on these small pieces of land, which now these are the things we have to deal with. To the urban Indian communities saying, the Western philosophy of trying to acculturate and reduce or rid of cultural identities in these communities was to put them in urban Indians. So as I mentioned with my family, my mother, she chose Oakland to leave home because the government came in and said, we'll pay for you to leave and get a job. And at that time, my mom she finished high school, but she didn't have a job, or she wasn't going to go to school. She couldn't go back home. She'd been raised in a boarding school, but she needed to make money and she wanted to help her mom and her family. So she said, this is probably the next best thing. But that then removed her from her home, removed her from her cultural way. She didn't speak her language anymore. I mean, so these are just those things that have happened. So this is just one of many stories that have shared. So they do use that term, and they do use these examples and stories that absolutely fall into the historical traumatic origin intergenerational trauma.
Okay, great. That's good to know. How are we supporting our incarcerated urban AIAN youth?
Yeah, that's a good question. And I saw that on there. Somebody had asked that before. And I think that's definitely a need, but I do want to mention that there is a Native youth specific residential treatment program down here in Southern California And so that's definitely trying to help reduce that incarceration, but I don't know exactly how otherwise that's done. That's just based on my knowledge from this work here. But I know that, again, the youth are so important to the work that we're trying to do. And so if you have a community that's really been impacted by substance use in general, it can be very difficult to find a sober mentor, you know, a sober family member, or somebody that, you know, some of the youth programs of trying to get, you know, good, you know, individuals that have been sober, right, to help these individuals. So, sorry, I can't fully answer that question, but I just know there is definitely that need to address and help them with youth programs in the communities.
Thank you. Any idea if COVID disrupted the supply of drugs to this community or these communities despite COVID-19?
Okay, wait, say that again.
Has COVID disrupted the supply of drugs into these communities? Have you seen that in any of your data collection, or is anyone looking at that right now?
Yeah, we're not looking at it. I don't know if that's happening. And I know, as I mentioned, we've kind of put a pause on some of our work in going to the community because we don't want to burden them. So that I'm not sure.
All righty. It's an interesting question.
Mm-hmm.
Please talk about the intersectionality issues of young adulthood and womanhood in the current crisis, if you can.
Yeah, that's a good question. I think somebody had asked that before too, and I couldn't, I had it bolded and I wasn't sure I'd get to it, but you know, there is this, again, the importance of culture and importance of maintaining their identity and making sure our youth are on a good road in their journey in life. And I just know that at least one thing that I had mentioned is that when women are, and actually men too, but there was actually a lot of mention of if they go to an in-house program and, you know, an in residential treatment program, and they have children, that they want their children to be with them. And I know these types of programs exist, but that really helps, you know, solidify the foundation of a family, and especially when somebody's trying to get help. So, I mean, I have had family as well that had their little ones with them, and it's a successful story, you know. So I too see that more of that is needed and happening for just our young folks and women in general. But the other piece that I think is important to note is today is actually a national awareness for the missing and murdered Indigenous women that's happening in our communities. Another issue that's really hitting our communities hard, where we don't have the data in our own tribals communities. We do, but there's a lot of missing and murdered Indigenous women for many reasons due to discrimination and racism and other things that have happened, and what do you call that? Sex trafficking as well. So that could be linked to some of this, but I think obviously more work would need to be done to really, for me to have a better answer on that too.
Thank you. What sort of networks are available when collaborating on this issue on a county or state level here in California, should somebody want to get involved?
Yeah, that's a great question. I think a number of ways. One is through those 5 tribal map programs, because they are in the community for the community, doing things, you know, with partnership and collaboration with the community. But then the other is through those coalitions now that are being developed. I think that's really another important piece, is they're trying to figure out ways to, one, work not only with their tribal council, but then also at the county level. And the state level. And so we are getting additional funding where we've added a policy piece to this so that we can build up advocates in the tribal urban Indian community to be those advocates, to talk at the state capitol and talk to our legislators, to talk about these important issues as it relates to not just substance use, but a number of things that you saw that came out of this needs assessment. So that's something we're really excited about, to help build that piece, which is always missing, because our communities unfortunately are always reacting oftentimes to things that have been happening in their community. So we're really looking forward to that, and that should happen or start up at the end of fall this year.
Awesome, thank you. One more question about getting involved. We have some students who are interested in an MSW placement. Are you all, is there a place for MSW students in the work that you're doing?
I mean, there's always room. We have, so we have, I know, a few PhD students, graduate level students, and the MSWs. Actually, we do have one native. I don't know if she's on this chat or not, but she's a native master's in, I'm sorry, getting her PhD, sorry, but a native PhD student in the master's in School of Social Work at USC right now. And she's a part of this as well. And so there is a number of opportunities to help as we are looking for the assistance to not only help support us, but we want to help support other students who may have never worked with this population before, to understand this population, as we too are always just trying to build up those advocates so that, you know, we don't often always have a Native person at the table, but at least they can say what's being done for this community or for other priority populations as well. So if folks are interested, please feel free to reach out to me and we can see how we might be able to support that and have the benefit of both ways.
Thank you. That's great news.
Mm-hmm.
And we have one last question, a live question from Noble.
Mm-hmm. Hi, Noble. I can't hear them.
Can't hear them either. Here we go. I think they're ready.
Hi. You kind of touched on it a little bit. I was wondering how I could get involved as well. So
yeah.
Same question.
Yep. So please go ahead, just email me. I'd be happy, and just let me know that you're on this this webinar today. That'd be great.
Awesome. Thank you so much.
Yes, thank you.
Well, I think we all agree this was an excellent presentation, and thank you for spending so much time on questions. There's a lot more, so if you have questions that weren't answered, please email me and I'll link you up, or just email Dr. Soto directly. I really appreciate your time and coming today. We have another presentation next Tuesday at the same time, and then another presentation the Tuesday after that at the same time. So please keep joining us for our virtual lecture series. Adam, did you want to say a couple words?
No, just echoing everything. Outstanding talk, Claradina, and thanks to our audience for participating and having excellent questions.
Yes, and Kristen, if I can encourage you to please share this out with others, if you're able to do that with the report, that would be great.
Absolutely.
Awesome. Thank you.
Thank you, everyone, for joining.
Have a great day, everyone. Stay safe, stay healthy.
Thank you.
Bye-bye.